our last speaker would be Dr. Chinmayee. She would be talking on central eye movement disorders, internuclear and supranuclear.
Very good morning to all of you. Just continuing with Dr. Jyoti's thoughts and the panel's thoughts that it's mostly the clinical examination and an imaging and video recording your cases, because later on you can actually find out the missed findings that you couldn't identify at the initial thing. So mostly in neuro-ophthalmology, many of the things are just 2 + 2 = 4, like these cases of ptosis, hypo and exotropia, pupil involvement. So we know it's third nerve palsy. Similarly, diplopia in outward gaze, we know it's sixth nerve, and a head tilt with an inferior oblique overaction, we know it's fourth nerve. But there are certain situations when the eye movements and the cranial nerve pathologies are not correlating, and that's when you have to think that there's something different that's happening, and you have to go into depth. And at the initial thing, if you do not understand, revisit your videos, because I'm going into the pathways above these nucleus. There is the supranuclear pathways, the internuclear pathways, because we only concentrate about the nuclear and the vesicular down that, but there are a lot of connections. Can't explain in the 7 minutes, but it's important for us to know all the pathways for the pursuits and the saccades, both for the horizontal as well as the vertical eye movements. And I think I'll skip this video, which Jyoti has already told the internuclear ophthalmoplegia. You just note the abducting nystagmus that you can see. So on the right eye, you see the abducting nystagmus, and the left eye, the adduction deficit. So this is a case of left internuclear ophthalmoplegia. Many of the times the imaging may not pick up anything, but then it is the clinical sign itself is enough, because these lesions are very, very pinpoint lesions which may not be actually evident on an MRI. So a contrast and if you tell them this is the area that I want to focus, the radiologist will be able to locate. This is another case with a vertical gaze palsy. Lot of other skew movement, deviation and other things also. And this is another patient. Jyoti also told about the vertical movements. You can also see that Collier sign, the lid retraction that is there. So this is a case of combined horizontal and vertical gaze palsy when the disease spills over the entire midbrain. Okay, and this is another child with dengue encephalitis. Here I want to demonstrate the convergence retraction nystagmus. So the same in continuation with Jyoti's talk. So you can see when you ask the patient to look up, you can see the eye is converging, and you're getting that conversion and the retraction nystagmus. So again, this imaging, you can see the lesions around the medulla-mammillary body and the thalamus. So when you are requesting the MRI, it's better the ophthalmologists don't request the MRI, but you put in your findings to the neurologist, and if they want any additional finding, they can add other things, particularly in children, because we don't want to repeat the investigations again and again. So you tell, this is the focus based on the eye findings, this is the area I'm suspecting, and based on that they can ask a particular imaging. This is another child, known case of SLE, kidney affected, complained with a difficulty in near vision. Okay, so that is when I'm doing the RAF rule, and for the conversions it is normal, she's not having any difficulty. But when I put on the reduced Snellen's chart, that is the test which you use for the accommodation insufficiency, you can see that this is where she has the blur point. And so that is reduced, and it's a very nice device, very cheap, and gives you objective values. So here, as I add her the plus lenses, you can see that the near point is coming back to her normal age. Okay, and she was like in her high school, and it was getting difficult for reading. So I have prescribed her reading correction till these bleeds and all. She was put on steroids, and later she recovered. But during the interim period, I have given her the plus lenses. Many of the time, if the convergence is also affected, then you kind of give prisms as well. This is the, so this is her imaging. As you see here, microbleeds is all that is described. At the end, like you can see that there are multiple microbleeds in many parts of the brain, and our finding will actually sometimes clinch the diagnosis as to where these points are. And this was our intern who started complaining of sudden onset of double vision, and he had a cross diplopia. So he actually had a kind of small ESO, but with a cross diplopia. So that is the thing when you have to think it's not a lateral rectus paresis, but we are dealing with a divergence insufficiency, because in a 6-nerve paresis you don't get a cross diplopia, but you are here getting a cross diplopia, and it was getting neutralized with the 6 diopter prism. And since he was also a myope and it was only 6 diopters, he was I think -4 or so. So for him I have just given a prism, like decentered the lenses to give a prism effect. So he was happy with that, and also working in the department. So again, it's very important, like we cannot see all these cases as a random squint case or something. A little higher order thinking is required when your findings are not fitting into one box. So to conclude, understanding the complex movement disorders, basically what it does is it helps us in localizing the lesion in the brain, because everything, the radiologist, I mean, it is so difficult for us who know the symptoms to identify where the lesion is, and the neurologist, the radiologist will have no clue as to what to describe. So it is for us to read the imaging finding, and the management is conservative. It's mainly glasses, prisms, and Jyoti told about the medical treatment for the nystagmus. Usually these are with association with the neurologist. Baclofen is the commonest drug that is used for the nystagmus associated with these conditions. And of course, as ophthalmologists, we can give prisms and glasses. Botox can also be used in temporary cases. Mostly in the, I think if there are, I mean, no students here, so I think it's mostly us, but the book by David Z is an extremely nice book to read about this neurology of eye movements. Thank you so much.
Thank you. I want to ask any question?
Any discussions like from the audience as well? Okay, thank you, Dr. Chinmayee. That was a wonderful presentation.